very warm welcome to all the, delegates who are already registered. Today is a great day. We are going to talk about a very important, topic in clinical cardiology, antiplatelet therapy. I will say not only in cardiology, there are many places antiplatelets are being used. And we have an excellent senior faculty, not only good in knowledge, but also in skills, Professor Tani here, to talk on that topic. I'll just make a very small introduction to this topic. See, commonly what we see in medicine is atherothrombosis. Right from Boyd's years, we have been listening to it. There is a blood vessel. It has a wall with a smooth muscle. Inner lining is endothelium. And there are some lipids which are getting accumulated there, which are being washed by another part of the lipid system. Then it goes for an endothelial dysfunction. A lot of inflammatory cytokines are secreted. They come to the place and cause a platelet aggregation along with RBC. And the end result is a vascular thrombosis. This is a common pathogenesis of any vascular disease. Let it be in coronary, let it be in cerebral, let it be in peripheral. Anywhere it can be there. And what we are going to address is a part of the antithrombotic therapy. All of you know that antithrombotic therapy has three arms. One is an antiplatelets, another is anticoagulants, another is fibrinolytics, which all of us know. But today we are going to discuss on antiplatelets. Why? Antiplatelets are the prominent components of an arterial thrombus, whereas our RBCs are a prominent component of venous thrombus. That is why in arterial thrombus, like a myocardial infarction or a stroke or a peripheral artery disease, we always encourage, rather we utilize antiplatelets. Whereas when there is a venous thrombosis, deep venous thrombosis, or a venous side of it, we always go for antithrombotic drugs. And a small introduction about antiplatelets. The moment you talk about antiplatelets, all our brain immediately says it is aspirin. There are various forms of aspirins available, 75 milligram, 100 milligram, 150 milligram. There was, I think most of you may be aware, there was an injectable aspirin way back 30 years. Along with our streptokinase, it was launched as an injispirin. We used to use it as a poor man's antithrombotic drugs. The second line is an ADP receptor antagonist, wherein we have two. One is thienopridine, that is clopidogrel and prasugrel, which we are very much aware of it. We are using it over a decade. Now the current one is a ticagrelor. It is the main armamentarium of our interventional cardiologists. We'll see what Dr. Tiny has to say. The next group is the glycoprotein 2B and 3A receptor antagonist. That also we use it in various critical coronary vascular lesions, and tyrobifon is being very commonly used. Now, many drugs are on the pipeline. Cankrelor and Paxar are in the pipeline. I am sure we will have the current data as on 2020 June, that will be provided to us by our faculty, Dr. Tylee Nair, which is a senior interventional cardiologist functioning as an interventional cardiologist with PRS Hospital. For over 30 years in Trivandrum, and to his credit, he has many accolades from the Royal College, the CSI and European College. And most important thing that I liked is in his areas of interest like coronary artery, young hypertension, heart failure, antithrombotic is his area of interest. We are going to talk about an antiplatelet, which is a part of an antithrombotic. A person who has an excellent passion for that will be able to definitely highlight the best to us. Thank you very much. Now over to Dr. Tiny. May I request you to go ahead with your presentation.
Thank you, Professor Ruraj. Thank you so much for that excellent introduction. Give me a moment when I share my screen. Yeah, I think I'm visible and audible.
Yes, sure. Sure.
So, the topic, as Professor Arul Raj has introduced, is beat the clot. We are all physicians who use antiplatelets day in and day out. So we will not go into the nitty-gritty, but look into something that has come fascinatingly interesting in the last couple of years. To understand that, let us first rewind ourselves to 500 million years, at a time when life form was just evolving. It's unusual to understand that life form evolved deep down there in the deep, dark, cold oceans. And from an unicellular organism, we grew into multicellular organisms, and then we thought we have explored the entire ocean. But then the fascination, the interest of looking at the sunlit land was always there for every form of life. As years passed by, interesting, as years passed by, animal forms slowly tried to peek out of ocean water where they lived into the sunshine and land. And as we progressed, the amphibians gradually came on to lands, and as you can see there, we moved on to land from water. And from there, the journey was one way and continuous. We became entirely landborne, and finally, that is the Neanderthal man, and we are on land. Like, this has been a journey which is ongoing, and we never looked back, except one. And that's interesting. The one mammal that looked back, and went back into the ocean, into the water from land, was the hippopotamus. Yes, the hippopotamus went back from land to water. And not just that, he created an entire line of mammals. For example, the beluga whale, that is the bottlenose dolphin. All of them are a lineage that went back. They are mammals, but they went back from land to water. But why are we interested? And that is because when a mammal has, with its circulating blood, went back to ocean and tried to live its life in water, taking deep dives into those dark, cold waters like the dolphin and the sharks do, there was a problem. There was intense vasoconstriction of the peripheral arteries, and there was a chance that the blood would clot. Now, if we take out the platelet from a human platelet, and side by side compare with a dolphin platelet, it's very interesting. Look at that. The dolphin platelet on the right is far more larger, far more granular, and you can see it is structurally entirely different. But this different dolphin platelet does not clot when the shark or the beluga whale or the mammal in the sea takes a deep dive into the cold depths. And that is unusual. And today, if you see, the entire research is focused onto that. For example, if you look at this is what came in Science Advance only about a couple of months back, very interesting, genes lost during the transition from land to water. The genes that are lost during transition from land to water, if you look at those genes right there, hippopotamus to human beings, you see a large number of those genes in red box there had been deleted. So that opens up a possibility that probably with our today's technology like CRISPR, if we are able to silence some genes, we might actually get an antiplatelet agent which might be good in preventing bleeding, preventing clotting, at the same time not increase bleeding like that we see in hippopotamus and the waterborne mammals. But then, till that comes in, let us look at something even new. We have to move forward to 1962. This is interesting, and this is important to understand what we are going to talk. Come to 1962. We all know that there is an autonomic nervous system. The nervous system that automatically works, and we are not responsible for it in comparison to the voluntary nervous system. And that has one sympathetic nervous system and another parasympathetic nervous system. So autonomic has sympathetic And parasympathetic, we know that sympathetic is fight and flight, while parasympathetic is feed and breed, right? So the autonomic nervous system is organized this way. And that is what we knew, we believed, and we continue to practice. But then in 1962, there was a significant change when Dr. Geoffrey Bernstock from King's College London did an unique experiment and found something unusual. You might say, we are talking about platelets. Why talk about the sympathetic nervous system or the autonomic nervous system? This is it. What Dr. Bernstock did was, he took a Taenia coli of a pig and then mounted it on a petri dish and started giving it shocks. But before that, he treated the Taenia coli, the smooth muscles, by an anti-adrenergic agent. So he took an anti-adrenergic agent, guanethidine, and treated the sample with adrenergic blocker. He gave atropine to the cholinergic receptor. So what he essentially did was, on that strip of muscle, he put an anti-adrenergic, anticholinergic. So he knew that essentially he has absolutely silenced the nervous system in that muscle strip. Okay, so we knew that sympathetic, parasympathetic, adrenergic, cholinergic, all silenced. And then he started delivering shocks to that muscle piece. And you see what you see there, very interesting. After a few shocks, at the end, he landed up with a huge muscular contraction. So he said, oh my God, what is this? I have inhibited adrenergic system, I've inhibited cholinergic system, but then still I get a huge big spike. So he said, he named it, he didn't know what it was, he initially named it non-adrenergic, non-cholinergic system. He said that's the system, it is non-adrenergic, non-cholinergic. Initially he said, I don't know how it works, and later on he said, this is a purinergic system. A purinergic system is something that is ATP dependent. So all these years we thought that ATP is the cash for the cell, right? It is what powers the cell. It is the currency that keeps the cell running, the fuel for the cell. But we never knew that ATP can also act as a neurotransmitter. So for the first time, people knew that there is a purinergic system, non-adrenergic, non-cholinergic, but purinergic system. And then over time, we knew that there are a lot of receptors for the purinergic system. And if you remember what Professor Arul Raj told you about the antiplatelets when we talk about P2Y12 inhibitors. Many people don't realize what is P2Y. P2Y is purinergic receptor 2Y. That P stands for purinergic receptor. So from that offshoot of autonomic nervous system, we got the purinergic system. And today we know purinergic system is not just a sympathetic system, not just a neurotransmitter, but it is there in very many organ systems in the body. And if we inhibit a P2Y12 receptor, we gain a lot. And as we know, if we inhibit that by clopidogrel or prasugrel or ticagrelor, we get significant antiplatelet effect. When we were students, maybe me and Professor Arul Raj, we were students, the platelet used to be a very simple thing. You have had a thromboxane pathway and an ADP pathway. Suddenly it has changed. This is from last month's journal Nature. These platelet functions all cut open, very complicated. Let us make it simple. We know that the platelet attaches to certain things to get activated. For example, lamin, collagen, fibrinogen, von Willebrand factor, leave them alone. But once the platelet is activated, there are a couple of systems that come into play. And the first, as you see there in the red round, is ADP. And the ADP acts through P2Y12 receptor. So if we block the P2Y12 receptor, what we do, like clopidogrel, prasugrel, and ticagrelor, we block the ADP pathway, the P2Y12 dependent platelet activation pathway. Then, of course, we had the classical, like Professor Arul Raj said, the moment you think of antiplatelets, you think of cyclooxygenase, and you have the aspirin. The thromboxane release is inhibited by aspirin. Then, of course, you have the protease activator receptor, or PAR1. And today we have an excellent drug. We are not talking about that today, but very excellent drug called Vorapaxar, which inhibits PAR1 receptor and acts as a good antiplatelet agent. But then hold on, before we, this is all that we know. Hold on, something else which we were not understanding till recently. If you look at the platelet, there's an outpouching, right? That red round. So when a platelet is activated, an area of platelet tends to pouch out, and that shows that the platelet is getting activated. And if you see on that activated outpouch area, there's some green blobs, dark blue blobs outside. They are phosphatidylserines. They are a series of protein structure. They get attached to those pouched out area. And that makes the platelet more susceptible for clotting. We will come to that in a moment's time. Now, yeah, those are the small blue blobs outside the outpouching, which are phosphatidylserine. Now, last year, we understood something absolutely new. And that is, we knew that the platelet, we always say about platelet count and the count the platelet in peripheral smears, but we suddenly understood that in a human being, one person, we have different kinds of platelet, subsets. One of the platelets, this is in Nature last year, is called an aggregating platelet. The aggregating platelets, like any other platelet, but they have a more affinity to attach to another platelet. Then, of course, we have the procoagulant platelet, a platelet that tends to secrete chemicals that convert prothrombin to thrombin and make the milieu highly coagulant. And then, of course, third, we have something called secretory platelets. These are platelets that secrete a lot of chemicals. We are learning about them. Apart from coagulation, they might be involved in a lot more complex pathophysiology, which we are just understanding. So let's say you and me, all of us have some aggregating platelets, some procoagulant platelet, and some secretory platelet. But we are interested in this. There's a platelet called collagen and thrombin coated platelet, and this is how it looks like. So the platelet gets multiple outpouchings, and they're coated with phosphatidylserine, and on top you see a lot of collagen and thrombin. Now, this coat platelets normally amount for about 7 to 10%. Every person is quickly becoming a marker for heart disease. So if I have, say, 25% coated platelet, tomorrow you might say, oh, you are likely to have a myocardial infarction. So quickly we are learning about coat platelets, which stands for collagen and thrombin coated platelets. Collagen and thrombin coated platelets. Now, this is interesting. This is interesting because, for example, Professor Arul Raj talked about GP2B3A blockers. For years together, we were using them. We were using for ACS, non-ST elevation MI. We were using in cath labs. We thought we are doing great. Finally, when we sat together and put all the trials, we found what? We found that if you look at one on the left favors treatment, right favors control, absolutely nothing. So at the end of all the trials, today we say that GP2B3A blockers are good antiplatelet agents, but they do nothing to the event rate. So you might say, why? We didn't have an answer, but today we know that GP2B3A blockers increase coat platelets. And because they increase the subset of coat platelets, may be the reason why we don't get any benefit out of it. So an antiplatelet need not just reduce your platelet activity. It has to reduce certain subsets of platelets for us to get a benefit. Okay, from that, let us come to what we already know. This is revision. Next 3 slides are revision. One, of course, we know we have the clopidogrel, which we have been using for years together. What do you know about it? Clopidogrel is sluggish. He's sluggish. He's not a very bright fellow, right? He takes 2 to 6 hours to act. He's suboptimal effect. Unreliable, because we know that there is ABCB1, we have cytochrome P452C19 for metabolism. So this is not a very reliable metabolism. It is unsocial, it doesn't mix with others. A lot of drug-drug interaction. So we say that clopidogrel is unsocial. And finally, the benefit of clopidogrel in white is low cost. So it's absolutely cheap. If you take prasugrel, we all again use prasugrel, not much, but once in a while. It is faster, it's good, they are faster. It is optimal. It is reliable metabolism, though it goes through cytochrome P450. It has a narrow spectrum. So we should be careful when we use it for people who had a previous CVA, people who had bleed before, people who are elder, more than 75 years of age, or those who are thin-built. So thin-built, elder, past history of bleeding, past history of CVA are the group of people who don't really do well with prasugrel because they might have bleeding. And of course, we should very clearly know that prasugrel has not been proven for medically managed acute coronary syndrome. They have not been proven for medically managed acute coronary syndrome. And of course, we should be careful about CABG. If you're going for CABG, prasugrel needs to be stopped for 1 week's time. That's an advantage of ticagrelor. We'll come to that later. Now, if you take ticagrelor, which is the newest kid in the reason why we are sitting here for this discussion is for discussing about ticagrelor. It is fast. 30 minutes it acts. So that is a significant advantage. Second, it is, of course, optimal. Reliable metabolism. So if you give it to your patient, you can say that it's reliably metabolized, and I'm sure that my patient will get significant platelet inhibition in 30 minutes time. Broad spectrum. It has been used in ACAs, in post-PCI, in every kind of clinical syndrome. Of course, we should be careful about prior stroke and TIA, where there should not be bleed. Again, there's lots of benefit in elders and thin. Maybe if we have time in discussion, we'll take that up. And of course, all these years, we said that ticagrelor is great, but its foot was, the pedestal was built upon just one major trial called Plato, one major trial. So, but then that trial was very robust and very strong. We'll come to that in a minute's time. So this is what we already knew. We already knew from a couple of trials about dual antiplatelet therapy. The first one is called CURE trial. In CURE trial, we had a group of people who were treated with placebo and aspirin on top and clopidogrel plus aspirin on bottom. So clopidogrel and aspirin was compared to aspirin alone. And we have seen there's a 31% risk reduction at the end of 1 year and few months, you see about 400 days. And that was tried in about 2,658 patients. And we said very clearly after CURE, 2 is better than 1. Dual antiplatelet therapy came into being from that point of time. So we knew that if we give a dual antiplatelet agent, which means one acting on, let's say, thromboxane pathway, one acting on ADP pathway, P2Y12 pathway, we get benefit. So 2 are better than 1 was the concept that we understood once CURE trial was published. But then we went on. Then came the Triton-TIMI trial. And that very clearly showed that compared to clopidogrel plus aspirin, of course, prasugrel was far better. 1 in efficacy in the triple endpoint of the top bar, you can see top line. The blue is clopidogrel and the brown is prasugrel. Cardiovascular death, MI, stroke was decreased. And not just that, the bleeding did not increase in prasugrel. Just after that came Plateau, which was a comparison between clopidogrel and ticagrelor. And we again found there was a significant benefit of triple endpoint of cardiovascular death, MI, stroke in Plato trial with ticagrelor. And then we very clearly said that ticagrelor aspirin looks like one of the best combinations because it is predictable, it is fast, it is quick, it is effective, and very clearly it has shown that in the dual therapy, compared to clopidogrel aspirin, ticagrelor aspirin is better. And you can see the p-values, it was significant. Now, what is the new data in 2019? Before we come on to 2020, what is new in 2019? And that was the first concept that all these dual antiplatelets are built upon on top of aspirin. So can we reduce the time for which we give aspirin? Is aspirin that essential? After maybe a couple of 3 months, can we stop aspirin and continue only ticagrelor? Because ticagrelor theoretically looks so good. And that answer came from the trial called Twilight ACS. Twilight ACS was published in 2019. This is a ticagrelor with aspirin alone in high-risk patients of coronary intervention for acute coronary syndromes. Now, the trial went like this. Look at the bottom of the graph, bottom of the slide. High-risk patients, about 9,000 patients were taken up. Of them, about 4,000 had ACS. For the first 3 months, they received a combination of aspirin plus ticagrelor. Ticagrelor 90 milligrams twice a day, BID. Aspirin 75 milligrams daily. And then they were randomized to the red line on top, where they continued to receive ticagrelor and aspirin for the next 3 months to 15 months, 12 months period, or ticagrelor and placebo. Yes, ticagrelor and placebo, which means just ticagrelor. So after 3 months of dual antiplatelet, we switch them on to either ticagrelor alone or ticagrelor plus aspirin. The idea was not to see whether we get a benefit. The idea was to see, are we reducing bleedings? And yes, when we looked into the data, this data looked into the BARC bleeding. BARC bleeding is Bleeding Academic Research Consortium, BARC. Bleeding Academic Research Consortium is a group that defined bleeding. You know, there is TB bleed, there is so many bleeding definition that creates more complicated international definition of bleeding, so much of complication. BARC bleeding basically 0 is no bleeding, 1 is bleeding that needs some action, 1 is bleeding that does not need action, 2 needs action, 3 is bleeding which is more severe, between 3 to 5 grams, needing either hospitalization or transfusion, blood transfusion, or producing tamponade, or 3C is called intracranial hemorrhage, 4 is CABG associated bleed, and 5 is fatal bleed. So in this, they looked at BARC 2, 3, and 5. 4 was not there because CABG was not taken into account. And you see that in this trial, there's a significant reduction of bleeding when we use ticagrelor alone. And that was a fantastic benefit. Even if we produce same effect, the bleeding was significantly less. If you see that data, 7.6 versus 3.6, almost half. And if you look into the data, there was a 0.47 hazard ratio, means 53% reduction of event rate. And if you look at death MI stroke, it was exactly same, 4.4, 4.3. So this showed us that at the end of 3 months, we can probably stop dual antiplatelet, ticagrelor and aspirin, and switch on to single antiplatelet, ticagrelor alone. And in this particular subset, it seems bleeding would come down, but the efficacy is not compromised. And that was an absolute new learning. The new data that came in 2020 basically piggybacked on the Twilight data. So 2020 ACC was presented the Twilight data where they took out patients who were diabetic. Interesting. So Twilight patients of high risk with diabetes, and that is called the Twilight DM study. They're the same population Twilight, taken out those who had diabetes and looked into whether same thing, ticagrelor versus ticagrelor plus aspirin, which one is better. So this is how it went. Again, 9,006 patients. There were 3,395 diabetic, as you see there, and of them 2,620 diabetics were taken up. You can see that part is first 3 months. First 3 months, they were all given ticagrelor plus aspirin, and of course, all the usual medication. And then they were randomized double-blind into either ticagrelor and aspirin on top, or blue ticagrelor and placebo. And then they were followed up for 12 months, that is at the end of 15 months, and their data was analyzed. And the criteria, this is interesting, we should know that because this translates onto our clinical practice. Twilight criteria, clinical criteria on the left is age more than 65, female gender, troponin positive. One of those PAD, CAD had to be there to be included, and this subset took only those who were diabetic. And then from the angiographic criteria, there had to be any one of the following: multivessel CAD, target lesion, a long stent, or a thrombotic target lesion, or a complicated lesion. So one complicated lesion in the angiographic criteria, and one diabetic with a patient with diabetes from that Twilight population, which means we are fairly talking of a significantly high-risk person. Not that they were low risk. You might say that because they were low risk, you gave only ticagrelor and they benefited. And if you look into the baseline characters, this is important because was the baseline different? Ticagrelor plus aspirin on the left and ticagrelor alone on the right. You see 915 patients on the left, 883 patients on the right. They are evenly matched. Everything looks evenly matched and no different. But when we looked at their bleeding rate, again, the BARC 2, 3, or 5 bleeding, we see there is significant difference. 6.7 versus 4.5. It translates on to a hazard ratio of 0.65, meaning that 35% reduction, relative reduction of bleeding. 35% reduction of bleeding is a significant value. And with that is the significant value, that is the bleeding. And when we looked into the death, MI, stroke efficacy, we found that they were not different, despite the fact that ticagrelor placebo had a slightly better performance of about 5.9 and 4.6, but we see that the hazard ratio 0.77, the confidence interval touches 1.09, so it is not significant, p-value of 0.14. So this is same. So what did we find? The efficacy in preventing death, MI, stroke, the triple endpoints of ischemia, are same, but bleeding was significantly low. So that again tells us that even when the patient is diabetic and high risk, you should probably stop antiplatelets at a shorter period and continue only single antiplatelet of ticagrelor. So then from the same trial of Twilight DM, they tried to look at, okay, I have benefits in reducing bleeding, and I have almost similar efficacy. So if we minus the efficacy from the bleeding, how much do I benefit in net? That is called the net clinical benefit. The Barksey bleeding, death, MI, and stroke, we found that the hazard ratio was 0.61, meaning that roughly about 39% reduction of benefits, whether it is avoidance of bleeding or reduction of death, MI, stroke, whichever way you look at it. And the NNT was 30. NNT is number needed to treat. Whenever a number needed to treat is about 35 or 40, it is significant. So you need to treat 30 patients to avoid one event, either a reduction of bleeding or avoidance of bleeding or reduction of either death, MI, or stroke. So in clinical sense, we actually benefit. Now, so conclusion of the Twilight DM trial was compared with ticagrelor plus aspirin. Ticagrelor monotherapy reduced the risk of clinically relevant bleeding without any increase in ischemic events, consistent among patients with or without diabetic undergoing PCI. So with diabetic group and without diabetic group, both benefited with ticagrelor monotherapy after 3 months. In the follow-up in the same ACC 2020, which went virtual, they also presented Twilight Complex. Twilight Complex again was an offshoot for the entire Twilight trial, but that excites the interventional cardiologist in a significant way. I'll show you why. So they were high-risk patients with complex anatomy who had undergone percutaneous coronary intervention. So they are like the anatomy looked bad. Anatomy looked bad on the angiogram. So what was defined as bad anatomy? So complex PCI included any one of the following. You had either complex PCI included triple vessels or more than 3 lesions, total stent length of more than 60 millimeter, long stents, add up everything and the length is more than 60, bifurcation lesion, any devices, atherectomy, rota used, left main as a target vessel, or venous or arterial bypass graft as target. The graft got blocked and you are doing a PCI on the graft, or chronic total occlusion. You have opened it. So all by definition, and a very complex lesion. Then was just a simple lesion. You go ahead and put a balloon, dilate, and put a stent and come out. So in this complex background, why it is important? Because we know that complex procedures have a far more aggressive or worse outcome. More aggressive, more complex the procedure, more you do rota, more you do an intervention, the chance of recurrence becomes obviously more. And in that background, what did monotherapy of ticagrelor do? Did it prove its benefit? Again, same kind of flow chart. 9,006 patients. Complex PCI was in 2006, 20 patients. And you see the first 3 months, they were on ticagrelor plus aspirin. And then they were put on to either ticagrelor aspirin or ticagrelor alone. And then same scheme. And then they were followed up. And when we see the components, this is interesting, components of complex PCI, they're really complex. Like say about 50% had long multiple stents, more than 60 millimeter total stent length. They were there in 50%. 3 lesions were treated in about 30%. CTOs, chronic total occlusions, were there in 19%. Okay, so left main was in 15%. So they were truly something of where we would enter the cath lab with a feeling that, oh my God, let nothing happen, right? They're all high risk cases. And in that high risk background, what did we find? We found this. Here, if you see complex PCI and non-complex PCI, the benefits were same. So we are looking at basically bleeding. The red is ticagrelor plus aspirin or ticagrelor plus placebo. In complex cases, the red top and the red dotted is complex PCI. The green and the green dotted is non-complex PCI. Now you see the difference is same, whether you see complex and non-complex, the difference is same, which means the bleeding is significantly less, whether you are looking at complex cases, whether you are looking at non-complex cases. And that is important. Not just that, if you look at death, MI, or stroke, you see they are not really different between any of them. So reducing antiplatelet therapy from dual to single after 3 months, if you include ticagrelor alone, does not enhance the event rate. And that understanding of 2020 is something absolutely good. So why we are so bothered? Because, understand that every time we add a new antiplatelet, a new antithrombotic, or a new fibrinolytic agent to our therapy, we benefit but ischemic events, but we increase chance of bleeding. And here we see that right after 3 months, if we reduce our antiplatelet intensity, we don't lose. There is no increase in bleeding, but the efficacy remains same. So overall net we benefit. So conclusion of Twilight complex was, among patients who underwent complex PCI as defined by a combination of high-risk angiographic profile or procedural features, a regimen of ticagrelor monotherapy after 3 months of DAPT with ticagrelor plus aspirin was associated with a significantly lower clinically relevant bleeding without increasing the risk of ischemic events compared to continuing DAPT. And that, I think, is very, very important. Just one slide before we finish is always this is in doubt that how long to give DAPT. See, everybody says this guideline, that guideline. Guidelines are there to just guide us, right? You are the clinician. At the patient bedside, you decide what is the best for him. A guideline just gives you an overall idea. So if we look at the duration of dual antiplatelet, the guidelines, we say that you should choose a shorter guideline, have the concept, shorter guideline if it is a more stable CAD. Suppose you have taken an angioplasty you have done for a patient who had just chronic stable angina because symptoms were more. There, the chance of getting into problem of ischemic events are low. Okay, if you are taking a person with a high bleeding risk, you don't want much antiplatelets to go in. He had history of bleeding, so we keep it short. So we keep a duration of dual antiplatelet short if the patient has stable CAD or a high bleeding risk. In contrast, we keep it long. We would give it for 1 year. Even we might prolong if there is an ACS and PCI on that background. We are scared that if we stop at 3 months, will there be a problem? And where there is very high ischemic risk. So high bleeding risk, we would give a shorter therapy. If there is high ischemic risk, we give a longer therapy. Shorter therapy today is as short as 3 months. And longer therapy can be as long as 12 months. It is individually your decision. You can do a bleeding risk, you can do a risk score, and then assess. That is your business. The idea is, if a patient has a high bleeding risk, give shorter period. Patient has a high ischemic risk, you can give a longer period of time. Now, with that, a very unusual data came in 2019, and that was about stable coronary artery disease. We are not talking about unstable syndromes anymore, not ACS, not MIs. Now we are talking about a chronic stable angina. So ticagrelor in this study was tried in patients with stable coronary artery disease. And that trial is called a THEMIS trial. This was presented in the European Congress last year. And we were all there in Paris. We heard this data presentation. This is roughly about 20,000 patient data. And the data analysis was very interesting. Stable CAD, 19,220 patients. They had to have an age over 50 years and have to have diabetes, simple. So stable angina, age more than 50, type 2 diabetes were included. And when they looked into the data here, that data is a primary composite endpoint. That means death, MI, and stroke. Blue line is ticagrelor, red is placebo. You see there is death, MI, stroke. There is a difference. The ticagrelor is better than placebo, but not much. You see the hazard ratio is 0.90, meaning that a relative risk benefit of 10%, modest. Now understand that this modest becomes very important because we are talking about a stable disease, right? In an acute coronary syndrome, the incidences are high. So effective drug quickly shows a difference. But here, the stable disease, you may not find a difference whether you use a statin, whether you use aspirin or clopidogrel or ticagrelor. The difference may not be that obvious, but in that background, THEMIS produced a 10% reduction of primary event rate. That was interesting. But hold on, what was the problem was here. That is, we found that the bleeding is significantly more. And ticagrelor returned a bleeding that was 2.3 times higher. So yes, in chronic stable disease, angina, ticagrelor in diabetic did produce reduction of event rate, but increased overall the bleeding rate. Okay, so this was kind of a not very positive trial because bleeding is increased. But what happened was then they tried to look into which population bleeding was less and benefit was more. And then they found that a population of patients in this category who had an angioplasty in the past, but now they have class 2 stable angina, these patients did better. So they named it as THEMIS PCI, 11,000 patient data, and showed that there's a difference. The treated group had an absolute event rate of 7.3%, and the placebo group had 8.5%, significant difference. So even if you calculate the bleeding excess, it gives a benefit. In fact, that particular subgroup is something where even if the patient is stable, probably we should think about adding ticagrelor to their therapy. Now, and that is the reason why that came in 2019. Just about 3 days back, this date would be there. That's June 1. Yeah, that is June 1 if you can read the date. FDA extended ticagrelor indication to high risk CAD primary prevention. So somebody who has maybe a high risk for developing coronary artery disease, he has diabetes, multiple risk factors, you can probably use. So there was a lot of debate. FDA said that today we have data to say that even those who have a higher risk in that THEMIS trial had a reduction of death, MI, and stroke in the future. So if the patient does not have excess chance of bleeding, why not start ticagrelor on the basis of the data that is already available? But today, for the high-risk CAD patient, preventing an event. Here, don't confuse primary prevention with a person who does not have heart disease. Here, we are talking about a patient of high-risk coronary artery disease who did not have an event. There's no MI, no stroke, nothing. So, using ticagrelor as an antiplatelet agent to prevent a future event. Now, this is the last slide. We should very clearly understand this concept before we go home, before we take up the questions. And that is this. The moment we used aspirin, like Professor Arulraj said, aspirin is the aspirin. Okay, we found that there was a benefit in event rate of about 22%. When we added clopidogrel, we saw an even 20% relative risk, not absolute reduction. We added ticagrelor, we got another 20% reduction every time. It looks so good. The data is the ATPC, the cure, and the plateau data. But understand this concept. This came in Lancet last year. They have said that as in any disease, as you go on adding antiplatelet to antiplatelet and then anticoagulant, for example, if you read that aspirin, clopidogrel, vitamin K antagonist, aspirin plus clopidogrel, dual therapy, triple therapy, you progressively increase bleeding rate. So as you benefit your efficacy of ischemia coming down, do pause and think before you add another antiplatelet. It's very easy to write, okay, aspirin plus 1 clopidogrel, let it remain. We see many prescriptions coming from physicians where aspirin plus clopidogrel for a chronic stable angina or plus minus chest pain. But remember that patient may not actually need it, because the point is that if you hand up, he may have a bleeding. You might say, in my practice, I don't see bleeding. The bleeding person may not come back to you. He might come back to me, get admitted with intracranial hemorrhage and die. He or his family may never know that this has happened because I prescribed an antiplatelet. So the point is, every time we add an antiplatelet or an anticoagulant, any antithrombotic to our standard therapy, the risk of bleeding increases. There's no avoidance of this. So we should be absolutely careful before we write what we need to do, because that is the famous Niagara crossing, and you know that. So we say that bleeding versus ischemia is a tightrope of antiplatelet therapy. And like we said, like we began our slide with the deep sea, we say probably human beings have a lot to learn from those bottlenose dolphin trick or two. So thank you for your time and attention. And I request Professor Arulraj to take over. And if there are any questions We would be happy to answer, try to answer. If there are any comments, please, if there are anything to teach us, please do that. Thank you. Your audio is off.
Thank you, Dr. Tiny. Very authoritative presentation on antiplatelets. There was an excellent blend of academics and clinicals. I mean, the way how the platelets aggregate and form a clot, and what are all the mechanisms by which this could be prevented. What are the available drugs? It's positives and negatives. Excellently you analyzed. You have made the point very clear. Number one, ticagrelor as on date is the best effective antiplatelet with least complication. The end point is good, but complication, especially bleeding, is much less. Second point is the combination, the dual antiplatelet therapy, which is going so popular, has to be for the shortest duration, to be decided by the clinician with all the available parameters. Thirdly, still aspirin has a role. I, for the one who always have a lot of faith on aspirin. See, I happened to go through an article in New England Journal of Medicine about 3 days ago. End of May issue. There was an excellent article. That is a combination of ticagrelor and aspirin for the primary prevention of a coronary artery disease or a stroke in diabetic people with 2 more comorbidities. And it has been, they have proved so well that the incidence may come down, but the risk of bleeding is really high. They have put us a warning query that don't use these 2 drugs together, which you have very well substantiated with science. And I have, as I told you, I am always for being older physician. We always still bet for aspirin. What there are for and against arguments are there. Aspirin alone as a primary prevention in diabetic people who have some more risk factors, either as an age or a lot of lipids or hypertension. What is your experience on that?
If you had asked me that question a couple of years back, we were prescribing aspirin for private prevention for every diabetic, but we don't do it today because we know that the chance of bleeding is high. And all these years we were basically fooled by thinking that in our clinical practice there is no bleeding, right? A patient whom I treat, he gets a bleeding, GI bleed, he would go to a gastroenterologist somewhere, he will not even inform me. The patient, he gets an intracranial hemorrhage, will go get operated by neurosurgeon in a third hospital, will never come back to me. So we always thought that minor bleedings are never reported. So very often we thought that bleedings are minor and they don't probably occur. But when we looked into the data, we did find that the risk-benefit ratio for aspirin is not very strong as a primary preventive agent. But like you said, as things go up, as risks of event rate goes up, they become more and more effective. So if there is any coronary artery disease, yes, aspirin. But absolutely, a diabetic walks in just because he has a couple of risk factors. Today, we would say that we will probably weigh and give aspirin, and it's a personal decision. Yes.
Thank you. There are, a lot of queries from the, from the delegate. There's a very interesting, query. Okay. That is, what is the role of ticagrelor 60 milligram twice a day in today's practice? 90 milligram is the common dose. 60 milligram is coming up. Our own senior cardiologist has only put forth this question to you.
Yeah, see, 60 milligram came in after the Pegasus trial where they tried to put people on 60 milligram BID after 1 year and see that the whole intention is simple. We try to reduce event bleeding and at the same time reduce ischemic event rate. So the Pegasus data did show that 60 milligram BID is good, and today, as a rule, what we are doing is that at the end of 1 year, those who are continuing ticagrelor, we are changing them to 60 milligram BID, because at one point of time, we are all telling that don't give much of antiplatelet beyond 1 year, right? And now we have just changed our tack and we are saying that at 1 year time, we have so much of event rate coming up after 1 year. So why not give an antiplatelet and we can reduce them? So I think if your patient is otherwise fine, there is no excess bleeding, and you think that his ischemic risk is high, probably you can put them on ticagrelor, because ticagrelor, the problem was that it is a very costly drug. So if we give ticagrelor, and if the patient even skips one tablet a day, like he takes, many patients will come and say, because sir, it is very costly, I am taking one a day. There's no efficacy at all. So we should be very careful before we write ticagrelor in an indication where it is soft. So patient who has a high ischemic risk, low bleeding risk, I would still continue to give ticagrelor after 1 year, 60 milligram BID. And that is what we do in practice.
Thank you. There is a question to Tiny.
Yes, sir.
What is the antiplatelet you recommend after 1 year of complex PTC?
Complex PTCA.
Yeah.
See, if it is in complex PTCA, and if the patient, we know the anatomy. See, in India, let me tell you, in India, most often complex PTCAs, we don't do a total revascularization, simply because, see, Chennai may be different here. The cost is a main factor, right? If you tell the patient that you have a very complex disease and you might need 6 stents, he will say, oh my God, how much of money and all that. So many often, the results are not complete revascularization, but they are partial. And such complex lesions, we would have used a rota, we would have used a device, we might have done a decay crush or whatever it is. Such patients, I always feel that their chance of getting into an ischemic event is high. So if their bleeding risk is low, I would continue on 60 milligram BID even at the end of 1 year. Yes.
Yeah. See, in this corona pandemic, one of our colleagues have put forth a question. Deaths in corona are now commonly said due to thromboembolism. What is the drug therapy for that, he has asked. May not be totally relevant, because when there is a thrombus in the pulmonary circulation, the management is going to be with antithrombotics. But he has put forth this question. He's a senior general practitioner from South India. You can highlight.
I don't be the ideal person to answer that, but see, we know that there are multiple thrombi in small arteries, microvascular thrombosis in COVID, but we don't know that by giving low molecular heparin or some antiplatelet, will it improve outcome? That data is not there. Sir, what is your opinion, sir?
See, actually, there are a lot of trials now available with anticoagulant therapy, and they have proved that the efficacy, or rather the outcome, could be improved to up to 42%. Even yesterday, there is an article, there is an entity called a happy hypoxia, or a silent hypoxia. Even one patient, after 7-8 days of treatment, totally recovered. He was having his breakfast in the dining hall, he collapsed. And they say this happy hypoxia may be due to, vascular episode due to, thromboembolism. Now in the drug therapy available, rather the regimen or the guidelines, this has come in. I'm sure, it will have a lot of effect in the years to come. One of our very academic physician has put forth a question. May not be fitting into this, but still, since you have highlighted a lot on the pathophysiology of arterial glut, clot, he wants to know what the difference between the pathophysiology of venous and arterial clot.
Yeah, that is what you said. That's what Professor Gulad said.
This is only platelet, that is platelets plus RBCs and fibrin. That's the thing. And there is another person. In our Twilight results trial, in what patients, what type of patients do you hesitate to use ticagrelor?
See, ticagrelor single therapy, if you're talking about ticagrelor single therapy, that is what Twilight tried out. Yeah. I'm very hesitant in reducing them in patients who I know who had multiple vascular episodes. I'm not talking about diabetes background. I'm not talking about the people who actually had a bad anatomy, but a person who had multiple MIs or multiple ACS drop positive, probably you'd still, despite all this trial data, I would still say that we would continue on dual antiplatelets to be on the safer side. That would be my take, provided they are not a person who has excess bleeding. If he has in chance of excess bleeding, I think certainly today we have data to say that we have that strength, that yes, we have data, we will reduce it and go for single antiplatelet.
There are two very interesting questions.
Yes, sir.
One, is there any single dose ticagrelor is available? Number two, something like a low dose aspirin. You have any low dose ticagrelor in people who are highly prone for bleeding?
Yeah, see, the load, one is sustained release. Some company in India was trying to actually, they said that they're developing a sustained release. Only about a week back, somebody called me and said that I'll send you some data. Can you look into it? They're developing in India, one of the Indian pharmaceutical companies is developing a sustained release ticagrelor. But I am not sure about the efficacy. You have to look into the DPDT, you have to look into their pharmacokinetics and pharmacodynamics. You have to see the release pattern and see how the antiplatelet function actually continues, how they prevent event rate. I am not sure. They are not available commercially. They are not popular. And second thing, low dose, we don't know. See, it is not a funny question. It's very interesting actually. All these years, for example, rivaroxaban, we were using 15 and 30 milligrams, 15 and 20 milligrams for pulmonary embolism, we were using for DVT, right? And for AF stroke prevention. Suddenly we have found that 2.5 milligrams of rivaroxaban, vascular dose, okay, in COMPASS trial showed that is so effective in preventing arterial events. In fact, because of lack of time, I didn't cover that. So today we are thinking about one P2Y12 inhibitor and a small dose of antithrombotic agent might be very good for prevention of arterial thrombus, even better than maybe single agent. So I think there is no trial available. But generally, if you look at the dose response curve of ticagrelor, it does not look like at the lower level below 60 milligram, it will have an efficacy.
Thank you, Dr. Taini, for an excellent, not only the presentation, I loved the good blend of academics and clinics. That's always, that is always needed. You need to, upload your brain, but you need to do, the best on the patient. That you have really done it, and a lot of very interesting questions. And there is one last question. With that, I think we will close it. That is, he has made a comment. Ticagrelor will replace clopidogrel in the years to come. What's your comment? He wants to know. With that, we'll close it.
I also believe that with the efficacy and benefit of ticagrelor, it might kind of partly replace clopidogrel, because there are two things here. One was the post-MI thrombolized group there, where ticagrelor was not effective. In a small study, they have shown that clopidogrel is probably safer and more effective. There's a pharmacogenomic trial that came in JACC just about 6 months back. They showed that probably if you are doing a pharmacogenomic based treatment, probably you can choose anything. The advantage of clopidogrel is that, we know that compound. We used it for so many years, and it's like a dog that we know for so many years, right?
Yes,
we are very confident with that, and it is cheap. And it's cheap. What? A rupee you get a clopidogrel. That is an advantage, and it has a longer half-life. Unlike ticagrelor, somebody says I have not taken for a day, that means his effectivity is gone.
Yes.
But I think over time, ticagrelor might actually replace clopidogrel. Yes.
Yeah. There is a, question just jumped in, but it's not on the cardiovascular. It is on cerebrovascular. Says the patient has got TIA, which antiplatelet you will give?
Oh, I think you have to ask the neurologist about what.
That's what I said. My postgraduate says he also wants to know from Nair.
Because nowadays we don't even use our brain. Oh, neuro TIA referred to neurologist.
With profuse thanks, let us close down today's academic discussion. I'm sure we'll meet on future academics. I'm thankful to all the delegates who have participated and put forth initiated a very good interaction. Thank you all. We'll meet in the next time. Thank you so much.
Thanks. Thank you, sir.
Thank you.